when they're doing their postgraduate, and they motivated us, especially me, to do internal medicine. So today we're gonna have another session of our AfroDX Clinical Unknown. Your presenter will be Dr. Fabian and discussant Dr. David. You're welcome all. To start with, chief complaint, I'll be presenting a 35-year-old male patient with joint pain for the period of 1 week and a half. Welcome, Dr. David.
Thank you very much. So, uh, 35 years old male with joint pain. So, first of all, I'm very excited to hear from Fabian today, and I hope to learn a lot from you too. So, this patient presented with joint pain. 35 years old male presenting with joint pain. So, this is So just to begin with, I think joint pain is something we've talked about a number of times here. And just like it's the case with other symptoms like headache, uh, you can be very comfortable. And especially me, if Joseph comes with a case of joint pain, he might start by saying David is very confident and comfortable with joint pain. But then new stuff comes up every day. So um, I'm looking forward to what I'm going to learn from this one today. So the way I approach joint pain is I will not um, I will not start discussing differentials, but rather I'll just highlight some pieces of information that I need in order to in order to see how I can make progress. So first of all, when I hear about joint pain, so the duration is important, the duration of these symptoms. But then, of course, another thing is when I hear about joint pain, I would like to know if which path I'll be taking from there. And one question will be, am I dealing with an arthritis, or is it just an arthralgia? So that's another question that I try to answer early on. Is this arthritis or just arthralgia? Because if someone presents with joint pain, especially if it's acute, you're talking of a number of days, it could be arthralgia from many of the things that are, including dengue that we talked about in the past 2 weeks. So it could be malaria, that is arthralgia. So my interest is, am I dealing with arthritis or arthralgia? And if I'm dealing with arthritis, then of course the number of joints and the pattern of involvement is also very important for me, because to that also helps to make progress on what exact pathologies are we talking about. And then on top of that, associated symptoms, in order, those will also help me make some progress, because there are lots of causes of joint pain. So yeah, I think I'll just end up there for now. And I look forward to hearing some pieces of information that I've mentioned in order to see how I can make progress.
Thank you very much, Dr. David. Let me proceed with the short HPI. So, as I've said, a 35-year-old male who presented to us with 1 week and a half history of joint pain, also presented with headache, subjective fever, malaise, and one episode of vomit. However, he did not record the temperature. Also attended a nearby dispensary where he was told he had malaria and was given alum. However, he reported to have no improvement of the symptoms, and 3 days later, he noticed his right knee was swollen and painful. Pain was present at rest, but wasn't when he ambulated or flexed the knee. It was associated with subjective fevers, chills, and general body malaise. 3 days later, his left knee became swollen and painful. Uh, 2 days later, that is the day he presented to us, his right ankle followed, which made him unable to walk without assistance. He also, however, he didn't report any history of having involvement of the fingers, toes, back, neck, or hip joints. No similar presentation prior to this. Also, he denies any history of rash, hair loss, eye pain, reddening, or photophobia, painful urination, rectal discharge, diarrhea, or upper respiratory tract symptoms.
Okay.
Okay.
Yeah. Thank you very much, Fabian. So can I see the first slide? Yeah. So what we see here, um, a, a week and a half presentation, and initially this patient reports headache, subjective fever, malaise, and then an episode of vomiting. So just like I said earlier, so many times actually when a case of joint pain is presented here, you are dealing with an arthritis. Many times that has been the case, but this is a new one. So we are talking about a case of joint pain, but what starts is this patient presents with initially symptoms that are non-specific, because when you hear of headache, subjective fever, malaise, and then an episode of vomiting, that could be anything, including the things that I mentioned earlier, like I mentioned malaria, which this patient was diagnosed with in the course of his symptoms. It can also be any of the other, for example, we talked about dengue, can also present with headache, can present with fever, malaise, and then the joint pains. So there's a number of infections that you probably need to consider. But then, so on top of that, we see this patient is diagnosed with malaria, but what we know, I mean, commonly, we cannot completely throw out the possibility that this patient was truly diagnosed with malaria, because you can see the symptoms. I mean, just based on base weight in our setting, when someone comes with a fever and a headache, one of the very first things that people try to rule out is malaria. So I'm not sure how this was diagnosed, whether it was an RDT or a BS, but then a diagnosis of malaria is made. But commonly, I would expect after this patient has been on treatment to have some improvement, and therefore the fact that the joint symptoms persisted and actually worsened, I think thoughts about malaria itself as a cause of the joint symptoms is fading. Now the fourth bullet there, so 3 days, I believe that is 3 days after the onset of the symptoms, the patient notes the right knee being swollen and painful. So when we talk about joint pain, so there's a number of things which I mentioned. I mentioned about whether it's an arthritis or just an arthralgia, the number of joints which is involved, and of course the pattern. So we start with this right knee that is swollen and painful. So when I hear swelling and I hear pain, I know that osteoarthritis can also cause swelling and pain, and the pain is worsened by activity, just like in this patient. But then pain of osteoarthritis, so commonly when I discuss joint pain and I mentioned inflammatory arthritis, I do not mention osteoarthritis. I take it to be a mechanical cause of joint pain. But so I think a number of things in this patient points me in the direction of an inflammatory arthritis. I mean, that could be premature closure for me, but then it's supported by a number of things. So first of all, there is swelling and there is pain. Those are 2 out of the 5 cardinal manifestations of inflammation. We talk of swelling, and that is tumor. You talk of pain, that is dolor, I think that is Latin or something, and then another thing is ruba, and the other thing is color. So color or color, if you want to anglicize it, but then color I think is so ruba is redness, and then color is about the temperature, and the other one is functionalisa. So this patient, this pain worsens with activity, and we are told at some point the patient couldn't walk without assistance. So that is some sort of loss of function. So I can see up to 3 cardinal manifestations of inflammation. And on top of that, the patient is having fever. And therefore, I think for this joint pain now that has progressed to become very localized, I think I need to entertain. I need to entertain the fact that this could be inflammatory joint pain, and therefore we are dealing with an arthritis. So before I start anchoring now on what differentials I'm considering, another piece of information is associated with fever, chills, general body malaise. Can I see the next slide? So what I remember from your presentation, yes, the first bullet of the slide is that 3 days later, the left knee becomes again swollen and painful. So a characteristic that I see here is, of course, maybe one thing that Joseph will need to clarify is that after the involvement of the left knee, is the right knee still swollen and painful, which means this joint pain is additive, or did the right knee get better and then the left knee became involved, which is pointing in the direction of migratory? So it's one of the two. We're either talking of additive joint pain or we are talking of migratory joint pain. 2 days later, the right ankle is involved. So right knee, left knee, and then right ankle. However, there is no involvement of the small joints, that is fingers, toes, no involvement of the back, neck, or hip joints. And then this is the first presentation. So the last bullet there is no rash, no hair loss, no eye pain, reddening, or photophobia, no painful urination, urethral discharge, diarrhea, or upper respiratory tract symptoms. That is a loaded bullet. So rash, some of the things I talked about, there are some infections, especially arboviral infections. Arboviral infections, some of them, there is one syndrome out of these syndromes, which is fever and myalgia. And another one is arthritis and rash. So arboviral syndromes, some of them do present with rash that is absent in this patient, hair loss. And another thing, of course, Joseph putting it there, he's also trying to think about autoimmune and connective tissue diseases in general. So, for example, if you mention SLE, it can come with a polyarthritis and a typical rash. Hair loss, again, I think targeted to ruling out autoimmune and connective tissue diseases. Eye pain, reddening, that is uveitis, which comes with some spondyloarthritis, and we've discussed the cases here in the past. And then painful urination and urethral discharge is about reactive arthritis. So this is a 35 years old male, probably sexually active. He comes with these symptoms. So that could be a possibility. Commonly, reactive arthritis is a monoarthritis. Of course, it can be an oligoarthritis. So upper respiratory tract symptoms, there are things. So for example, when you talk of acute rheumatic fever, that is a thing. And of course, I think it's one of the things that I'll need to entertain in this patient, except that the age is against it. Acute rheumatic fevers, As a consequence of a group A beta hemolytic streptococcal infection, a pharyngitis commonly more than a skin infection will present. Commonly, it's children and adolescents who are involved, but then the pattern of the joint pain is migratory, which is one of the differentials. There is acute rheumatic fever, but of course, in order to make a diagnosis of acute rheumatic fever, you have you have criteria that need to be met. So with this patient, all we see is a migratory arthritis, and we do not see anything else that is in keeping with a rheumatic and an acute rheumatic fever. Is there another slide, or this was the last one?
This was the last one. Thank you very much, Dr. David, for a very exhaustive explanation, especially when you talked about the five cardinal symptoms of the inflammation. It was far away fetched, but you were able to remember it. So I will go on and proceed with review further system. We reviewed cardiovascular system, whereby there are no any history of shortness of breath, no chest pain or palpitation, no significant or contributory history on the past medical history. On first family social history, he's married with two kids, reported to be multiple sexual partners with inconsistent use of protection. Doesn't drink or smoke. On the side of the mother, he's hypertensive, DM with knee osteoarthritis. Other family members are doing fine. Okay.
Okay, so and uh, Joseph and Fabian were very deliberate with this. You see, in the review of systems, purposely cardiovascular system I included there. Of course, I think other systems were a little bit touched in the history, but again, I think it was very important here to talk about the cardiovascular system, because if I mention a differential of acute rheumatic fever, then we need to see if the modified Dukes Jones criteria are met. Uh, so you see that this patient has joint symptoms, a migratory polyarthritis. This patient has no rash. So one of the major criteria for acute rheumatic fever, apart from the migratory polyarthritis, which is one, another one is erythema marginatum. This patient has no rash. So another one is carditis. And with carditis, you talk about pericarditis, which can present with chest pain, myocarditis, which can present with symptoms of shortness of breath. And then, of course, you also, it can be pancarditis. So you are talking about the pericardium being inflamed, the myocardium as well as the endocardium. So there are no symptoms that are telling us that the heart is involved in any way. Of course, another one is Sydenham chorea, which has not been mentioned here, but the fact that it's not mentioned, we assume it's not there. So major criteria, I see major criteria for acute rheumatic fever. We have one, and then a number of minor criteria. So I think as we proceed, for some reason, I need to entertain this diagnosis. I need to entertain it, but then because of the migratory nature of this joint pain, but then something else that I need to prioritize, although I should say, uh, because for this patient now, I think I can frame it as that up to this point, I might be dealing with an oligoarthritis. You have three joints that are involved. So there are two knees, and then uh, there is one ankle joint that is involved. So it's an oligoarthritis, but then it's inflammatory. it's an inflammatory oligoarthritis. I'm saying it's inflammatory because of the reasons that I explained earlier. So physical examination, of course, will help us clarify more on that. If there is tenderness to touch, if there is color change, that is erythema, and if there are any other symptoms that can tell us that for sure we are dealing with inflammation. But right from the beginning, I'm convinced to a large extent that we are dealing with an inflammatory oligoarthritis. So Joseph is telling me that it's migratory. So maybe if I can ask you, Joseph, do you mean that by the time the left knee is involved, the right knee had gotten better? Is that what you mean?
Yeah, that was the case. As the left knee is getting better, the right knee starts to be involved. And then, for example, the days he presented, it was just the ankle that was swollen, that was little inflamed, but the others were painful, but not that much inflamed as compared to the knee, to the ankle joint.
Okay, that's interesting. So, and yeah, I mean, this is a good day. I'm just passing time here and looking forward to learning later, because I'll tell you something. I've discussed the joint pain many times, and yeah, many times it happens that I figure out what is going on. But for this particular patient, I'll tell you, uh, we are dealing with the migratory arthritis, and with migratory arthritis, I have very few, if not just one differential, and that is acute rheumatic fever. I know there is a number of others, but then I think I do not have a very good approach to a migratory arthritis as compared to if I was dealing with an inflammatory polyarthritis. Then I could have a number of things, but then regardless, there is a number of things that I need to prioritize in this patient. So I've talked about a possibility of acute rheumatic fever, a number of things against it, but the joint pain being migratory in nature, I think I'll have to entertain it to a certain point. Another thing that I need to prioritize, again, there are some red flags, but the fact that this patient is presenting with joint pain, swelling, subjective fevers, uh, you need to make sure that you rule out infective arthritis, because infective arthritis can be very detrimental to joints if it's not attended. But then what is against infective arthritis is, so first of all, uh, it's not common for someone to have infective arthritis in more than one joint. Not common. I'm not saying it cannot happen, but then in more than one joint. And then, of course, for an infection to get into a joint, it has to get there through some ways. So commonly, it's actually hematogenous spread, and another one is direct. So, for example, from an adjacent, someone with an osteomyelitis, and then the infection spills over to a joint, or direct spread from a soft tissue, extension from a soft tissue infection. This patient didn't have prior symptoms, and then he started with a non-specific syndrome of headache, fever, an episode of vomiting and malaise. So I think we need to entertain more of a systemic process that later on comes to manifest in joints. And there's a number of things. Malaria is not one of them, because so commonly malaria, we talk of a myalgia rather than, we talk of an arthralgia rather than an arthritis. Although, yes, there are some infections that do present with inflammation in the joints as part of the presentation of these diseases. So things that are against infective arthritis is that there are some joints that improved to a certain extent without intervention. that if this patient is presenting with left knee pain, by that time the right knee is improving without administration of antibiotics. We have not heard about it. So it's less likely that at least that you are maybe talking about an infective arthritis, which is commonly will consider a bacterial cause. So that is something else. Although I think I need to consider it to a certain level, but then there are things against it. That being one of them, that there is improvement in some joints without intervention, and then the arthritis is jumping from joint to joint, which is not typical of infective arthritis. So acute rheumatic fever, infective arthritis, something else, um, reactive arthritis. It's an oligoarthritis or a monoarthritis. Again, the way I know it, not based on my knowledge of it, it's not migratory. But then reactive arthritis, because of the history that we had of multiple sexual partners, although we've been told that there is no recent history of urethral discharge uh, or anything that is in keeping with a urethral discharge syndrome, which later on presents with a reactive arthritis. Although again, this can also come with a GI infection. But at least we did not hear, apart from vomiting, which could be part of a larger syndrome, I do not see, and of course, this was very recent. So commonly, you talk about reactive arthritis coming a few days to weeks, actually, you are talking of 2 to 3 weeks after an antecedent urethral discharge syndrome or a GI syndrome, which is not the case in this patient. So acute rheumatic fever, infective arthritis, reactive arthritis. But then another thing now is that I need to think that this systemic process that presented earlier, and then later on a migratory arthritis, takes me back to acute rheumatic fever. But then I need to think about other infections. I know that there are some rickettsial infections that do present with an arthritis, a picture of arthritis. But then, as I've talked about in the previous presentations, I do not know any that are prevalent in our setting. So yeah, those are my thoughts for now. Let's proceed to exam. Maybe I'll get more clarity.
Okay, thank you very much, Dr. David. I will proceed directly to the physical examination. On general examination, the patient looked alert. He was oriented. However, he was in pain. Febrile, not pale, no jaundice, not no any peripheral lymphadenopathy, no rashes. On vital signs were all stable. On local examination, on joint examination, both knees and the right ankle were swollen, warmer, tender to palpation. However, there was active and passive joint movement. Other small inline joints were essentially normal. The rest of the systemic examination was unremarkable.
Uh, okay, so let me take some time here and maybe throw in a few more differentials before I discuss this physical exam. So I've mentioned acute rheumatic fever. I've mentioned infective arthritis. I've mentioned reactive arthritis. So right now, I think I need to activate a bit of system two thinking. I need to start thinking slowly. So other things that I need to consider. When you talk of the exam has helped me clarify that it's true that we are dealing with an inflammatory arthritis, and this is an oligoarthritis. In the history, we see a migratory pattern, but then by the time this patient is seen, these joints are still active. So we are dealing with an inflammatory oligoarthritis because it's three joints now, and that is something else, of course, that have problems with, because when you talk of an oligoarthritis, are we talking about 3 joints and less, meaning 3 being part of the equation? Or if you talk of 2 joints, that is what we consider as an oligoarthritis. But then if it is something more than that, if it is from 3 or more, we consider it poly. So the way I take it is that 3 or less is a polyarthritis, but then 4 and above, I take that to be a polyarthritis. So, and another thing that we do not see in this patient is symmetry. So yes, both knees are involved, but then it's the right ankle that is involved. The left one is not involved, and therefore I will not spend time talking about pathologies that present with symmetrical arthritis. And of course, for them, it's more of a symmetrical polyarthritis. So you talk of things like rheumatoid arthritis, SLE, and any of the other related diseases that you can think about. So when you talk about an inflammatory oligoarthritis, I think an infection is worth considering, and I have a differential there. Reactive arthritis is worth considering. We have a differential there. Another one is thinking about crystal deposition diseases. So gout as well as pseudo gout. So when you have deposition of urate crystals or calcium pyrophosphate crystals, those commonly, of course, we talk about a monoarthritis. So for example, when you talk of an acute gouty arthritis, commonly it's an oligoarthritis, and at least the initial presentation for most is in the large toe. That is what we know from the textbooks, but then it can involve any other joint. But then I think we also need to entertain it, because when you read, you will also find it's a monoarthritis or an oligoarthritis. So crystal deposition diseases, but then in the history, we do not see some risk factors that are in keeping with this, a previous history of the same presentation. This could be initial presentation, but then this again cannot be explained by the previous prodromal fever, headache, malaise, vomiting. They do not go together. And of course, we know some risk factors that will lead to either increase the production of uric acid or decrease the excretion. So like alcohol intake, people who are taking food rich in purines, that is not the case with this patient. But then I think I also need to put it there as part of the differentials. So another thing is some things that we do not talk about commonly, although we are told that there is no antecedent history of urethral discharge. But then another thing that can present in this way, that you are having active joints, and then there was an initial presentation, although we did not see a urethral discharge, at least currently, a disseminated gonococcal infection can present this way. But another thing that you would see is skin involvement. So you can have a rash, so a disseminated gonococcal infection. And another thing, of course, secondary syphilis can present with active joints. But then we were not told if this patient had a previous history. So, for example, a genital ulcer. Those are a few more differentials that I thought about adding. Now, coming to this examination, no lymphadenopathy. I think that is an important one. And then the vitals look quite unremarkable. Coming to the joint exam, just like I said, we see active inflammation in these joints. So both knees, left and right ankle are swollen, they are warmer, they are tender. You see, so you can see that you have at least, so what is missing here? There is tumor, there is swelling, there is color, which is temperature, there is change in color, that is rubor. And then you also see that there is loss of function. So you have 4 of the cardinal presentation. So there is active inflammation. And one thing that is important, no small joint involvement, other joints are not involved, and then you do not have presentation in other systems, meaning the cardiovascular, the GI, respiratory are all normal. So I think those are the differentials that I have for now. I believe that is not all. Let's proceed uh, to labs and imaging in order to see if I can make some progress.
Yeah, sure. Thank you very much, Dr. David. That was very profound and exhaustive. Okay, so I'll proceed with the lab investigations. CBC was actually normal with elevated ESR of 100 with normal renal function test. Uric acid were within normal ranges. BG was within normal ranges. Urinalysis was normal. Liver's enzyme were essentially normal. MRDT and lab test for HIV was negative.
Okay, this is interesting. So is this where this is just after these labs? This is where I commit to a diagnosis. This is interesting, and I will be point blank that I do not think I can come with a diagnosis at this point. But so I'll go back and make a problem representation for this patient. So we are dealing with a 35 years old male who presented with an so basically a 1.5 weeks history. Is still in the category of acute, but then I'll just put it that an acute to subacute presentation, which initially presented with non-specific symptoms of fever, headache, uh, joint pains, that was malaise, and an episode of vomiting. And then 3 days after this initial presentation, the patient starts with presenting with a migratory slash additive oligoarthritis. And notably, we do not see associated symptoms, especially in the cardiovascular system. And we also do not see any supportive symptoms of a systemic autoimmune process. This patient has no rash, has no hair loss, has no other symptoms that are suggestive of an autoimmune process. And then coming to risk factors, an important risk factor is that this patient has a history of multiple sexual partners, family history remarkable for hypertension and diabetes. However, we do not see autoimmune diseases in the family. Coming to physical exam, 3 joints active. So we are dealing with an inflammatory oligoarthritis. And then coming to labs, only ESR is elevated. So what is going on in this patient? A WBC count. So if we are, I think I'll just start discussing these few labs that we have here before I try to commit, which I do not think I can. But with these labs, so if we are talking of, so for example, an infective arthritis, it's still a localized process, but then over time, you can have a peripheral leukocytosis, which we do not see in this patient. ESR is elevated, which is telling us our patient is inflamed. And of course, when we talk of inflammation, I think in a tough situation like this, I'll just need to collect my thoughts and think around infection. I think up to this point, I have, apart from saying infective arthritis, I think I've not mentioned another infection. Okay, so far I've mentioned disseminated gonococcal and secondary syphilis, as well as infective arthritis. So I think I have some infections that I think about. I know that there are infections that can later on present with arthritis. An example is Lyme. Lyme's disease can present with arthritis, but then I'll tell you the truth. I've read about Lyme's, and I've seen cases of Lyme's outside this setting. But then, I mean, in our setting, I've never thought about making a diagnosis of Lyme's in a patient, because I'm not even sure if we have the bugs uh, uh, that can the ticks that can bite you and transmit the Borrelia that causes Lyme's. But that is an example of another infection that can present with an arthritis. But then, so I think I have a few infections that I'm thinking about. Then for autoimmune, unless we are talking, of course, reactive arthritis. Maybe reactive arthritis can be considered. It's an immune mediated, but maybe we should not completely say that this is an autoimmune process. But then, talking of the common autoimmune diseases that we talk about, they are not supported in this patient because commonly they present with the symmetrical polyarthritis, which is not the case with this patient. And then there are autoimmune diseases which do not present with a symmetrical polyarthritis. So a good example is you can have some uh, peripheral spondyloarthritis, which can present this way, but then this patient did not have any other symptoms that are in keeping with the spondyloarthritis. No uveitis, no back pain, so no other symptoms that are in keeping with that. Of course, it's hard to think about a malignancy that presents with just joint pain, unless you are talking of a paraneoplastic presentation, which again I cannot think about. I cannot think of on my feet. So I think I'll entertain more of infection, autoimmune, and of course I think for joint pain we go beyond that, because there is other inflammatory conditions like crystal deposition diseases. So yes, uric acid was within normal limits in this patient, but when someone presents with acute gouty arthritis, the uric acid can be completely normal. So but then, I mean, making a diagnosis of acute gouty arthritis in this patient, I have not seen risk factors that are in keeping with that. So if I am to commit to a diagnosis, I'm having a hard time in this patient. I'll not commit to one diagnosis, but then I will say I will need to investigate this patient further in order to make a diagnosis. If you are in an ideal setting, because this patient is having active joints currently, you need to aspirate those joints. And then when you aspirate, you send that synovial fluid for gram stain, which does not have very good yield. Of course, you can do culture on that. But then the most important is cell count in that joint. So cell count, and you see what kind of cells that you are seeing there. So if you see many cells in excess of 50,000 neutrophils, those ones can be pointing you in the direction of uh, an infection, especially. Of course, we talk of inflammation as a broad, but then with an infection, you expect the white cell count to be very high. But again, I say the likelihood that we are talking of infective arthritis, I think I'll keep that very low on the list. So what I will do is I'll send the synovial fluid for cell count, and then of course microscopy can also be done on that. I'm not sure if we can do that because you need polarizing light in order to see the crystals, whether what you are seeing are negatively birefringent or positively, and whether they are needle shaped or rhomboid crystals. So that is in gout and pseudo gout. So I think that can help us make progress. But in the meantime, what I'm keeping on the top of my list, I think acute rheumatic fever, I do not have enough evidence to make that diagnosis. Why? Because I only see one major criterion, and that is a migratory arthritis, no carditis, no erythema magnatum, no Sydenham chorea, and then the age of the patient again and the antecedent history, we are told no symptoms of an upper respiratory tract infection. So for that reason, I think acute rheumatic fever, I'm putting it aside, although it could be one of the things, but then based on criteria, because I see one major, and if I try to find minor, I think fever can be one of those. A leukocytosis is probably one of those. Of course, an elevation in inflammatory markers, including ESR, if I remember the criteria correctly, is one of those. And therefore, I think distantly, I need to consider a possibility of acute rheumatic fever. And I think I might be wrong in this, but then based on epidemiology, that is an off for me, and that is why I'm not entertaining it very much. But I think acute rheumatic fever is a consideration. So another thing is infective arthritis, not very much, but we have to make every effort to make sure we rule it out, and therefore send that synovial fluid for all the tests that I talked about. Reactive arthritis is commonly a monoarthritis. It can be an oligoarthritis, and with the history of multiple sexual partners, we can entertain it, but then no urethral discharge. But then I think this one is simple because you give anti-inflammatory medications, eventually the patient will respond. And therefore, I do not have a diagnosis to commit to, but then how I would proceed with this patient is I would make sure that I rule out an infection first. And if I do that comfortably, then I'll keep the patient on anti-inflammatory medications. If the patient responds, it's one of these things, a reactive arthritis. Of course, even arthritis of or the other arthritis that I've talked about will respond to anti-inflammatory medications. So the synovial fluid will help me rule out an infection and rule out crystal deposition diseases, of course, in an ideal setting. So I think I have like 4 considerations. I'm not confident enough to stick to one. So I would say acute rheumatic fever, a reactive arthritis, and of course I talked about a disseminated gonococcal infection and secondary syphilis. So another thing that I would need to do is to send a VDRL. And then I've also talked about crystal deposition diseases. So I think synovial fluid will help me make progress. Yeah, so that's where I am. I am not confident enough to commit to one today. Yeah.
Okay.
Yeah.
Good. So we were able to do a urethral swab, which was taken for calcium sensitivity, and results were as the culture yielded coagulase negative, gram-negative cocci and clusters, which were staph epidermidis and staph saprophyticus. There are no any gram-negative cocci that were yielded. And
And so
the
I
patient,
think Fabian.
yes,
Yeah. So sorry, I didn't explain this to you. So it was like this.
okay,
We sent the urethral swab for calcium sensitivity, and we initiated this patient on ceftriaxone doxycycline empirically, but the catcher came back with those organisms that the coagulate negative, gram positive cocci and clusters. The guy from lab said this has to be staph epidermidis or saprophyticus, which was a normoflora. And then they saw gram negative cocci, but they couldn't isolate it. Yeah, so that was the case. I think you can proceed.
Okay, so Okay, if I am, do I comment on this again? Yeah. So what I would say is, and thank you for this piece of information. So one of the things that I thought of, I talked about reactive arthritis. I also talked about disseminated gonococcal infection. But then, so the when you talk about urethral discharge syndromes, the commonest organism is Neisseria gonorrhoeae, which is a diplococci. But then these organisms are very fastidious. So culturing these organisms is difficult. So and that is why we treat syndromically in our patients. And in high resource settings, what they do is that maybe in order to confirm that diagnosis, what they do is that they send they send these for nucleic acid amplification tests. So these are gene-based tests rather than culturing, because organisms that commonly cause urethral discharge syndromes, gonococcus is the commonest one, and then followed by chlamydia. After that, of course, there is mycoplasma. So you can see most of these are very fastidious, and therefore, if you stay in, probably you have a chance of seeing them. But then, especially when it comes to culture, it's very difficult to isolate them because they are fastidious, and therefore a urethral swab is sent, and then culture results, you see a mixed colon. So coagulase positive, is that coagulase? Okay, coagulase negative, and these are in clusters. Of course, that is tough. But then gram-negative cocci. So because of culture, I'll be a bit pessimistic. Of course, Neisseria gonorrhoeae, these are diplococci. So commonly you see them clustered in two. But then, so I think theoretically speaking, it's very difficult to culture this, and therefore I have a hard time thinking that this is a gonococcus. But then, so what I would say is, at least to a certain extent, I think reactive arthritis and a disseminated gonococcal infection, they are things that need to be a consideration for me. So I think these culture results have not helped me make much progress because of my limited knowledge in that, and I'm pessimistic that usual culture would help grow these fastidious organisms. But then disseminated gonococcal infection or a reactive arthritis, due to his history, those could be possibilities. But then, so as I said earlier, still we need to make progress with the synovial fluid. Yeah, where do we go next, Fabian?
So we were managed to reach to a final diagnosis, and was disseminated gonococcal infection.
Yeah, thank you, Fabian. I think I should take over from here. Thank you very much. You presented very very nicely. Although you had a little time like reading the case, it shows if you
Yeah.
bring your own case here, it will be very good. You'll enjoy. Yes, David. A lot
Yeah.
of teaching from you, and most was correct. So Fabian, put the next slide. So this was our final diagnosis, David. I will tell you how we arrived at it, and you went together. So disseminated gonococcal infection. This is the spread of Neisseria gonorrhea, causing clinical syndromes which include arthralgia, arthritis, the case of today, tenosynovitis, or skin lesions which were not there. The epidemiology like that. 0.5 to 3% of patients who are infected with gonorrhea, like among all patients who are infected with gonorrhea, 0.5 to 3% will have the disseminated gonococcal infection. So historically, female were more affected than male, but currently it seems like it is reversing. Males being infected as the same as females. So it is said that although psoriasis is the most common cause of septic arthritis in overall, but when you come to the sexually active individuals, Neisseria gonorrhea is the most common cause of infective arthritis. The pathophysiology like this, and it's very important as in this case, it is said, as you see in the clinical presentation, most patients who will have a disseminated gonococcal infection, they won't have the genitourinary symptoms. It will be asymptomatic. That's why you didn't hear me mentioning anything, or Fabian mentioning anything. It was true. Patient was telling the truth that they didn't see any discharge or painful urination. So it is said because it is asymptomatic, it gets the time to disseminate. So that's among the one among the factors that cause the dissemination. But so if you have asymptomatic infection of gonorrhea, you have a delayed diagnosis because there is no symptoms, and then you have dissemination. But again, it has been observed that if you isolate blood or the synovial fluid, most of the time you won't see the organisms. So it is thought it is the immune complex deposition that is causing the joint issues rather than direct invasion of the organisms. And next slide, yes, Fabian. So presentation, very, very important. So usually there is no concurrent symptoms of mucous membrane infection, like there is no symptoms, the urethral symptoms or rectal symptoms or pharyngeal symptoms. Two clinical syndromes have been identified. One is called arthritis dermatitis syndrome, and the other is the purulent arthritis with or without associated findings. The second one is the case of today, but we should learn all of these. So with the arthritis dermatitis syndrome, you have a triad of tenosynovitis, dermatitis, and polyarthralgia without purulent arthritis. Like they will have joint pain, but without the inflammatory signs that David was talking about. And this start 2 to 3 weeks of primary infection, which actually we asked the patient, and we said yes, he had unprotected sex with another of his multiple sexual partners like 1 week ago. And so it begins with fever, chills, malaise. It is not usually not symmetrical. Usually like asymmetrical, as in this patient it was going. So if you see migratory arthralgia, this is a distinguishing feature of this thing, which was the case here. So if patient also have tenosynovitis or have wrist or finger or ankle or toes pain, the dermatitis, they'll have the painless vesicopapular rash. So the case of today, the purulent arthritis, with or without associated findings, these most don't have arthralgia or the rash. Like there is no preceding simple joint pain without inflammation. It come up abruptly as the inflammatory migratory oligoarthritis, as in this case. So most commonly it affects the knees, wrist, or ankles, as in this case. It's usually asymptomatic. Labs are very interesting. If you send blood culture, the rate of them being positive, the range is so wide. Like other case reports report 4, others report 70. So you see, it's a wide range, but mostly in practice, it's usually negative. The most important thing, because people wouldn't be like some of they won't report their sexual behaviors. So the you should swab the mucosa and send for Neisseria gonorrhea from like 3 sites: urogen, rectal, and pharyngeal. We swabbed this guy urethra because he told us he's female male sexual intercourse, and the preferred test is the nucleic acid amplification test, which we don't have in our labs. But if you send now, if catch is used, you should use the so-called thiamaltin media. I talked to the lab guy, very interesting guy, very intelligent. Told me it's yes, it's true. You need this to isolate Neisseria. That's why he saw the organism, but he couldn't isolate it. But there's no problem. If you read the differential diagnosis of gram-negative cocci, even if it is not Diplococci, it's so limited. It's Neisseria, which means Neisseria gonorrhea or Neisseria meningitis. There's no reason what is Neisseria meningitis is doing in the urethra of someone. And other like simple stuff that are so rare, like they are nothing. And if you consider them, you will miss the diagnosis. So if we probably had the thiamaltin media, we could isolate the organism. But the saying that they are seeing gram-negative was pretty enough for us to treat disseminated gonorrhea in this patient. If you send synovial fluid, okay, you can do cell count, gram stain, culture, but remember, it's only 50% that will come up positive. Treatment is very important. It's not treated as the simple gonorrhea with ceftriaxone starts. This is OD for at least 7 days, depending with the response of the disease. Because you hadn't checked chlamydia, these things travel together. You should also treat chlamydia with a doxy. And you should trace all sexual partners within the last 60 days, and you should treat them, but you treat them as you treat simple gonorrhea. Start dose of ceftriaxone, 7 days of doxy, and that is it. I called this patient like 3 days from we started treatment. He said there is some improvement. I think I have to call again after like a week and see if what I'm treating is right. So if you have, what I learned in this case, if you have a case like this, it's not sin to consider gonorrhea, because if you miss it, you are causing trouble. Let's say you think it's polyarticular gout. Polyarticular gout is the acute flare of gout is self-limited, by the way, even if you don't treat it. So gout will come again, and if patients present again and again, no, okay, I'm dealing with gout, even if I can't take the synovial fluid and send it to look for the crystals. As David says, septic arthritis, very important to be considered, but S. aureus as the cause of septic arthritis, usually monoarthritis. So as migratory oligoarthritis, think of gono. Doesn't matter what patient is saying, think of gono. Yeah, so David, this was the case. Thank you very much, Fabian. Very, very nice presentation. And maybe, David, can we hear from you?
Thank you, Joseph. It's been an incredible journey, and so I think a number of things to learn here. So I think what the experience has taught me, although yes, a disseminated gonococcal infection came at some point out of the blue, actually, because of as you were presenting, and then I think this is something else that I need to entertain in this patient. I think this has been a humbling experience for me, because although I managed to have that included in my list of diagnosis, but then I think the realization that I cannot read medicine and finish it, I think, is becoming clearer and clearer every day, because I think I've discussed I've discussed joint pain here many times. To an extent that Joseph is saying, I'm very comfortable with joint pain, but then you can still see how much I struggle to get my head around it as to what exactly is going on with the patient. So first of all, a humbling experience, teaching me a lot again, that there is still a lot more to be covered, even with joint pain that I've been discussing so many times. And number two is that so sometimes, yes, you do not see the way patients are presenting and what they are telling you. If you do not think wide enough, it's very likely that you will miss the bus and treat something very different. Because so what led to the consideration that we are dealing with possibly reactive arthritis or a disseminated gonococcal infection, one of the things was the history of multiple sexual partners. But you can see that with when we talk about this, we rely heavily on things like an antecedent history of a urethral discharge syndrome, which was completely absent in this patient. So that is number two. And number three, you can see the similarity between different conditions. So I think what saved me from acute rheumatic fever was epidemiology. But apart from that, you can see that this patient at least met one major criterion. And if you needed to consider minor criterion, at least the distant ones, you could still make a diagnosis of acute rheumatic fever. And the only thing that makes you think less about it is that, okay, in the past 2 to 3 weeks, the patient likely wouldn't have forgotten to have had a sore throat, for example. So no reports of that. And again, maybe these things are more commonly seen in children and adolescents and not in someone his age. So very similar presentation between many different diseases, and that added to the layer of complexity when I was discussing this case. So I think a lot of things to be learned from it, and thank you very much for bringing it up. I think I learned a lot today, so thank you very much.
Yeah, thank you. I think we are above the top of the hour. Do you have anything else from anyone? Fabian, you want to say something?
Yeah, so actually, I would take this opportunity to thank you, Dr. Joseph. It has been a very good experience. I hope I'll present my case soon.
Mhm.
I'm just preparing it. Yeah, thank you very much. I've learned a lot, Dr. David. Thank you very much.
Thank you for presenting. Looking forward to the case.
Okay.
Okay.
I do not see any hands. I'm not sure if there's anyone with anything. In case there is no one with anything, it's been good having you around. Hope to see you next weekend, and have a good night.
Good night.
Thank you.